to be, active back and forth, right? So you need to cut this one in 4, and then you can fold it like that, right? For the second page, and this is the basic concepts, right? We need to know what a thrombus is. Believe it or not, on the exam, still people got it wrong. Thrombus and embolus, we need to know the difference between the two, right? So to me, I need a connection to know, because they're very similar, right? I have ESL to begin with. And then, the brain is already flipped, and then another flip, right? So for embolus, I put the word embark. Embolus, embark. Like, I have something, right? Like, to help me understand that embolus is traveling. It's going somewhere. The thrombus is there. So I couldn't find a word for a thrombus to be static, but to a relationship for me to understand that it's static versus traveling. So then I decided to go embark. At least if I have one connection, I already know the other one is not. And this embark. Yeah, attach or park. Yeah, but through the word, to me, embolus and embark, they start with the same letters. Yeah, stays the same letters. Not really the concept, but a connection that I can understand in my brain. Embark, embolus. The what?
Just embolus and tree.
A tree?
A tree because they stuck.
But how is that related to the word?
Thrombus
tree. Okay, I like that. So put a little hair on the T, and then it's a tree, right? Like stays in there unless a hurricane comes, which is what happens, right? Yeah. So I decided to go for that. So to give you an example of the word that you can use to connect, that's how my brain works, right? I see colors, I see numbers, and I see letters. I can see connections with the letters. Your brain might be a little bit different. You might need to see an image. Then if that's the case, go ahead and get a picture of a thrombus and one of the embolus, right? Just flying through the river, right? So whatever works for you. That was my idea behind this one. Second page, we have the facts of ACDs. So on this one, what are the 3 ACDs that we went over? We went over the myocardial infarction, and which is STEMI or NSTEMI, and the angina pectoris, right? All the anginas, all of them, right? They fall into this, and then there's differences between them. But I need to understand which one is, what is it called? What is an ACD? Then, right, acute coronary disease, but within that, what are the 3 that fall into it? 1, 2, 3. And then STEMI and STEMI, and then all the anginas on the bottom, right? So you make those connections. So you can either cut them apart, and then I gave you a blank page. So you can cut this and organize it however you can understand it, right? However your brain works on that sense. This is a blank page. Thank you very much. And then these are the concepts that we can have for including the percentages of female and male that die after myocardial infarction after the year. And it might not necessarily be because of the actual disease.
Okay.
But it could also be for other conditions, right? Already present, metabolic diseases or renal failures or things like that, right? So yes, that's what you have. When you have a blank page, it's a work page, right? You can cut. My idea was to cut it, and I brought my scissors, but it was too much. I just came up with the idea so we can have something to work with besides the PowerPoint. And I grab all this information from your chapter. Literally copy, paste to the chapter. So all the information is there. That's what we need to know, yeah? I wanted to pull them. But this one might not work. Maybe Mr. Ochoa broke it. Huh? I'm gonna use another thingy. The next page is the myocyte necrosis. What is myocyte to begin with? So when you see something, if we don't know, I like to do key terms for every chapter, like what are the most important words that I need to know, if it's new word, or if I don't know, right? It's like talking in another language, speaking in another language, and you don't know the words. So What's a myocyte? Muscle cell, muscular cell, right? And necrosis. Okay, so I already know the muscle cells of my heart die when there's no oxygen, there's no blood supply, etc. Which sounds like a STEMI and STEMI, right? So this is what happens during when the blood supply is diminished to the myocardial cells. And ultimately, this is what a STEMI or myocardial infarction causes, the death of the myocardial cells, right? Because so we went back to the 90-minute, right? The golden rule, 90 minutes. So I didn't put it here, but you can add it here, right, to the facts of this. So we have the ACDs here, right? The angina, the STEMI, and the non-STEMI, and then you can put all the facts under that. So it's I don't want you to just look at it. I want you to work on the file, right? What can I put under there? What information do I have about the unstable angina, STEMI and non-STEMI? And then we have more coming up. Huh?
They all have similar symptoms.
They do have some symptoms that are exactly the same. So the person doesn't know. I was listening to a podcast yesterday, and the doctor was talking about somebody who was feeling different symptoms. And then when he asked the next question, he's an ER doctor. And I said, like any ER doctor will ask, right? And then the answer was generic. And then he went to the second question. And based on the second question, it's like, oh my gosh, go to, we're going to activate the code, right? So immediately for other labs and et cetera, et cetera. You know, the initial consultation is like what decides which way we're going. Yeah, on that one. Let me pull my PowerPoint, because then that's what it makes sense. Go through the PowerPoint. This is exactly the same pace that we're following here, right? Life-threatening, information about how many people die, and if they're, you do have this information on the second page. More information, this is exactly what happens. The obstruction happens, the disruption of the plaque, or a blood clot happens, and then this is what can cause the lesion. There are different ways that we are going to recognize what happens to the vessel, and this is how we are going to categorize and therefore act upon. But nonetheless, what we're trying to avoid is the myocyte necrosis. Yes? Okay, so you do have, I don't know what page is this anymore, because I have a wrong, hold on. Oh, this one that I gave you, myocyte necrosis. Okay, we have the 3 presentations, right? So this is a table from your book. It is on your book. So there is different, like I was saying, different presentations, and that's how we act upon. When we have unstable angina, that's a chest pain. That's maybe indication of Therefore, there is no necrosis in that. We are just starting to look at the symptoms, and it could be, chest pain could be anything really, gas, right? Depending on the other symptoms. When we have an NSTEMI, which is non-elevated, right? ST elevation, and STEMI, non-elevation. This is a partial, and we're going to see why in a little bit. This is a partial occlusion. Therefore, we have some necrosis because we're missing some of the flow, right? The difference to the angina is there's no necrosis. But that comes later, right? That's different. We're going to take a look into that. We're just looking at the urgency to take care of these things. And then, of course, we have a STEMI, which it will be a thrombus that will stop the blood flow to the myocardial cells. This is a STEMI. That's a heart attack. The occlusion of the blood supply that will create myocardial necrosis. Yeah? So in this, you can say yes, no, yes, yes, right? Like, just like in this one, right? But again, you are reading along with the PowerPoint, with your book, and then you're answering this question. So this is for you to answer this question. Myocardial necrosis in an angina? No? Yes? Yes, right? And then I have an amazing video. I don't know if you guys had a chance to look at it. We're not gonna look at it right now. This is the clotting cascade. Remember, I was looking for the word for the it was the clotting cascade. You're gonna have a few questions on your RCIS about how the body tries to heal itself. There is the different routes. Don't. You might have one or two questions on that.
You want us to know like primary versus secondary?
No, some of the questions will be like when we look at the table, for example, is going to be what is the pathway to fibrin activation? It could be the whole entire thing, right? Or we're just going to be the thrombin area. So it's going to have two questions like that. It's a very complicated response.
Internal because they would never anesthetize that what they did with factor 7.
So imagine when we have like people with hemophilia, right? So there are so many factors. So you're going to complement all these that you're trying to learn and put in the head when you go to clinicals. These things are going to start making sense. We might see, we might not. I never saw a right heart at my clinical site. Never. We never did a right heart. I'm like, okay, what do I do? I had to kind of just put it in my head. And when I had to do the first one when I was already working, I was like, okay, do the best and use the best that you can, right? So we're going to complement. And again, we as the tech are not going to make any decisions on what medication to give or what is the response, but we are responsible for recognizing some of the symptoms. What can we do when this happens or that happens? That's us. When we have a dissection, what do I do? I'm like, okay, it's bleeding, right? So no, I need to start activating, so that's my value as a tech, the anticipation of when things happen. Yeah. So please watch this maybe 2-3 times. Just know we have here the next page on the book. It's talking about normal hemostasis. So the body is going to recognize that it's hurt, right? Something happened. Either we make an incision, the plaque dislodged, or the clotting happened, either thrombus, thrombolytic, or embolytic. So it's an injury. And the body immediately is going to activate a response system, right? So the body is always trying to get to normal hemostasis, right? Regardless. The body's going to try to do that first. So how the body's going to try to do it to any injury is going to activate a platelet plug. That might not necessarily be good for us, right? Because it's going to generate the clotting cascade.
Yeah,
so it's going to create platelets. It's going to create more clots. So that's when we are going to start giving the patients medications as like the baby aspirin. Every patient that comes with a heart attack, they're going to get the baby aspirin in ER. They're going to maybe start on heparin, maybe ACE. So we activate this, my brain is somewhere else right now. It's going to activate the code, and then we're going to start giving this medication because we need to go against this plug. right? When the heart attack happens. Does that make sense? Now, the endogenous hemostasis, what's endo in medical terminology? Within. So the internal system is going to start creating a, clotting factor, what's lysis? Destruction of the clot. So the body's going to try to start activating,
Breaking it down.
Yeah, breaking it out because it's a form that the body doesn't recognize as normal. So the body's going to try to do these things. But this is when we go in with medications. Don't worry too much about medications right now because you're going to have your class on drugs. It's going to be a lot of fun. So this is going to be called anti-thrombolytic mechanism, right? Anti-thrombus. We're going to try to attack the thrombus, right? Well, the body, and then us with medication. Then I gave you sclerosis. I gave you a page. I gave you 2 pages of the of each table. My goal is that you cut every little single piece, and then you put it together, right? I gave you some. I don't know if I gave you some arrows to this one or not. Does that make sense? So you have 2 identical. One you're gonna cut, and you're gonna put it like a deck of cards. Which one is going? So test yourself. Like on the, we also need to know atherosclerosis and arteriosclerosis, which some of you still are confused about. Yeah, one is the hardening of the vessel, and the other one is the plaque. We need to know which one is which, yeah? So we're gonna have the 2 ways that the body is going to try to activate. When we have atherosclerosis, what's atherosclerosis? Is it plaque or hardening? Plaque. So that means we have something in there that is obstructing, right? The problem will be if there's a plaque rupture. So it's like I wanna think like when you are kind of making repairs on the house and you put a little bit of plaster and the plaster breaks, right? And then it travels, and the coronaries, as you know, they're gonna start. The diameter is gonna start thicker diameter, and then as they go through the heart, the diameter is going to reduce until it gets to the more distally areas. It's tiny, right? So depending on the plaque size, that's where it's going to lodge. And then we have more disease through the system, which more likely we are. This is what is actually happening. Imagine remember I told you it's plaque and it's sharp. So if it dislodges in through your the lumen of your vessel, it might be kind of like doing this when it's traveling, right? Like through the walls. Josh is like, oh. Because there's, the plaque may also damage the intima. So what happens if these injuries are happening? The body is releasing more platelets because there's more injury into that. So when we have plaque in the vessels, we haven't talked about the and I don't even know when we're going to talk about this. The blood flow, think about the river, right? If it's calm, if there's nothing going on, it's like nice and calm and quiet and going. But then when you get to the rapids, the rapids is nothing else but disruption on the elevation, right? There's rocks, there's things like that. So that's when the water starts getting all conflicted, right? Or what is a good word? Turbulent, yeah. So we are going to have turbulent flow, blood flow, and we're going to be able to experience that. All this is going to cause the platelet activation because it's like what is happening. So all those are when the plaque is rupturing, and then we also have the dysfunctional endothelium. So this one we're going to be treating. This is something that the patient already has. There's nothing we did or anything like that. So we're gonna go ahead and the body is going to either vasodilate or is going to try to prevent the thrombosis on its own. It's a reaction from the body without plaque because the endothelium is not healthy, right? So we need to differentiate. Either way, patient can have a heart attack, regardless, right? On the health. So this is what I want you to do. Start thinking about each one of the two is going to be the plaque created or how the body is, and then start acting on your little. How do we call it here? The map. It's a map. This is a map. Yeah. So that's why I gave you two. Yes. So this is how we can learn this particular one.
Pathology versus physiology.
Well, right. Yeah. We're going to start putting things together.
This would be more patho, and this is more.
That's how it is, right? It's physiology. That's a good way to look at it. Again, this is how the body is. Nothing that we have done. The next. Well, we kind of already talked about this, atherosclerosis. All right, let's talk about which page is this? This one. It's because the printer, for some reason, it said to print both sides. So I couldn't, I was like, ugh. So I had to print everything twice. Nice. They were trying to save, but not with me. And then I wanted it on color because it's so ugly. You can even read it. I was like, ugh. But the printer downstairs did not have color. I was like, okay, better than nothing. Right? All right. So let's talk about the coronary thrombus. A coronary thrombus is what's going to cause. Right? So either or, right? So we have a small thrombus, partially occlusive thrombus, and an occlusive thrombus. Those are the presentations for a thrombus, right? Nothing or dusty that could also cause actually a stroke. Yeah, it depends where the presentation is. But if you have your
it was within the internal carotid.
Yeah.
But we're at the tip of the.
If the plaque is here,
Yeah.
if your plaque is here, it's going to be on the head. If your plaque is in the coronaries, it's going to have a heart attack. If your plaque is in the renals, it's in the legs, right? So it depends where the presentation is. But at the end of the day, when we have vascular lesions in the peripheral system, coronary system, the whole entire system more likely is damaged. It's not just one lesion. It's rare that you only have one lesion out of nowhere. More likely it's a whole it's systematic, right? All right, so what is going to happen when we have a small thrombus? When there's really no issues, maybe the dust. Now for the head, it might be because it already happened. Not to me, but I already experienced that. The dust can cause, if it's in the brain, particularly because the vessels of the brain are way smaller than the ones on the heart, right? But let's talk about coronary thrombus right now. As the coronary thrombus increases, the problems also increase, right? If it's a small one, we wouldn't even notice. We probably all have it. And no changes in the EKG, and probably the body's going, when the zone system is going to try to take care of it. That's simple, right? Now let's move into the partially occlusive. In the partially occlusive, we are going to be, look at this, ST segment depression. This is going to be super interesting because that's the difference between one and another. The ST segment depression, and then we're gonna label it depending on other factors as an angina, unstable angina. When it starts, the occlusion, the thrombus starts being a little bit bigger than small, and starting the presentation with the chest pain, etc. But we don't have any biomarkers. There's no troponin, there's no creatine kinase, none of that, right? It's just kind of like there. Like, I don't know, I feel it's like when water is leaking, the little bit of leak doesn't really cause a lot of damage. but then it's until it starts causing any damage, right? So when we have an ST depression with serum markers, that's when we're going to call it NSTEMI. It's a partial occlusion with markers, and the presentation is, we're going to talk about presentations later.
And the markers are just like troponin.
Markers is troponin and creatine kinase, more likely. Those two. Let's keep it on those two. Yeah? So that's the difference between the angina and the NSTEMI. They're both are not emergency, right? Now, let's move on to the occlusive thrombus. Well, when we have occlusive thrombus, the ST elevations, they're not depressions, they're going to be elevations now. The markers are going to be definite, and I have it somewhere on the PowerPoint. The only way that we can really say that the patient is having a heart attack is with the biomarkers, especially the troponin. Yeah. We have, believe it or not, patients that present with ST elevations and then no serum. So it could be NSTEMI or it could be placement, EKG placement,
Oh.
right? Believe it or not, that happens too. So, let's see. Okay, so we see the difference between the three. You can do the same thing, play and see if you can organize, the 3 rows or the 3 columns. And so I gave you 2, right?
Yes.
Yeah.
I've seen some people who have like inverse heat waves, but they've never had an actual like episode or any MI at all.
Could be electrolytes
Like,
or past ischemic changes.
Previous. Well, that's another thing. When a patient has a heart attack and they never take care of it, and it doesn't have to be occlusive, it could be an NSTEMI, and they like, oh no, I'm gonna be fine. Da, da, da. The lesion is still there. The tissue dies regardless. So we are going to notice the changes in the EKG for years,
For years.
if not for always. Does that make sense? If the tissue died, there's no connection. The myocells are not longer serving the connection, so they're bypassing the connection. Does that make sense? And it might show on the EKG. And that happens a lot. People that don't take care of themselves, especially guys. It's weird, but it is true. More guys are like, no, I'll be fine, whatever. And we are like, more like, oh, no, my kids or something. The guys are like, I'll be fine. All right. And I don't know, in my experience, that's how it's been. That doesn't mean I don't have statistics. I just have my observations, right? All right. So then we have the causes of myocardial infarction. We have those on the little quiz, right? We talk, and it was kind of like just the obvious, right? But we need to know there's this and then some. There's some of the do the same thing, right? Test yourself, cut these lines. And then you start either working with somebody or start putting or writing them down. Because I gave you another empty page, so you can work on the concept. So you can have all the concepts that I'm giving you, put them in a pile, and then start putting them where they belong. Right? That's another technique. And then the people that didn't come, they're going to want the packet.
Right. I can take a scan and send it.
Yeah, we can. I actually have the file, so I'm going to put it on the modules so we can see it. So yes, on that one. So spontaneous coronary artery dissection. What do you think is? We just talked about it, but we did talk about that specifically. The dysfunctional endothelium, right? Obviously, trauma, aneurysm, increased blood viscosity. So the vessels are, the muscular layer, the second layer of your vessel. It's a little muscle, right, that allows for constriction or dilation. right? So when you do a fluid, I mean, try to drink water from a straw, and then try to drink mashed potatoes, right? So it's going to completely be different. So it's going to expand. It's going to make more effort, and that could also happen. And then hopefully, not having any other conditions, coronary embolism, vasculitic syndrome, et cetera, et cetera. So this is what it is for. Yeah, all the concepts. All right, let's talk about part two of your chapter. We're going to specifically talk about STEMI versus NSTEMI, and it's mostly the presentations and the treatment. Yeah. We used to have our pictures here from the groups. So, and they were like, I guess from the beginning, it was like a silver, you know how that frame is like silver? It's all, actually, I think that's ours. You know what? All this is ours. I'm gonna take it. Look, stroke. I'm gonna see which class is this, because those are mine. I'm gonna take them. You know how we have nothing in the room or get new ones, right? But look at those in the back. They're actually nice. You don't like them?
I like that one.
Cholesterol, we can have them, right? Well, I mean, we can get new ones. We can get new ones. Yeah. We're trying. All right. So remember that we talked about the difference in obstruction of the coronary obstruction to call it NSTEMI or STEMI. All right. So the STEMI is going to be transmural infarct. What does the word trans mean? Across. So that means it's going to involve the whole diameter of the vessel. Yeah? And now the NSTEMI is sub. What sub means? Under endocardial infarct. So I gave you on this image on your packet. It's not on the it's not on the PowerPoint. I mean, yeah, it's not on the PowerPoint. I just wanted to give you a visual of what the difference is. What's up? What's up?
I don't know. What's up?
Tell me.
Is there a bug?
Oh, it's getting on you. All right. So, so the image can make more sense. Yeah. So if the injury happens across the vessel, it's going to be a STEMI. If the vessel is subendothelial and only a part of the vessel, then it's going to be NSTEMI. Now, is that definite? Probably not. But then the definition, this is why the EKG looks the way it does. And I have the form in there. That's why we have either the, what is it called? The elevation or the depression. Thank you very much.
It really elevates that.
Oh, yeah.
Depends where you got, at what time you caught it. Because sometimes we got somebody who's like, you know what, I'm not feeling well. This is her. And then we catch it on the first EKG. It's like, eh. So we're gonna keep it on observation, and then 2 hours, and then until it gets like that. So it's actually called a tombstone because it does look like a tombstone. Yeah. While the depression is definitely
Can I show him?
obvious. Yeah, sure. Is it a real one?
Please show me.
Is it a real one from a patient?
No,
Oh,
no.
oh, I thought you were gonna talk about a patient.
No, I have, if I don't want to get fired.
No, you can get images as long as you don't get patient information. So when you go to clinicals, please, if you're taking a picture, tell someone that you're gonna take a picture and make sure that on the capture is not patient's name.
Right.
We can take pictures.
Okay, so just like the EKG, but not the patient.
Correct.
It's not the patient.
Correct. Yeah.
It'll be on top.
Yeah. And it depends. I have a doctor that he's like, no. It's my student. No. You're not even, because I like to take pictures of my students in the lab and things.
This
And-
just happened.
Right now?
Patient got shocked with an ACV.
Oh, man.
Dissection. I didn't know it was.
Well, it could be. I've only been into one aortic dissection, and she didn't make it.
Yeah.
And she didn't make it. I mean, it goes It's super fast. So, because I think it started happening when she was at home or not feeling well or something, and then in transport. So when we got her, there's nothing we could do. She was gone in like minutes. Nothing we could do. Feeling down, the pain does not go away, chest discomfort, and 25% of the presentations don't feel anything. The Supermans. Yeah, like, oh, I'm okay. And then all of a sudden, no. But I've heard the more awkward one was the indigestion.
With what?
The indigestion. You feel like, something is bad, and they even do like this, go to the restroom, and
then they code you.
and they code or die.
Did they push her?
No, because it's a heart attack. It's not indigestion. But they feel that and then they're by themselves, so something happens in there, and
What happened to me was I was on the phone with the nurse. I was like, hey, can you go check on the patient? You know, like, I'm monitoring his rhythm, obviously, and his heart rate kept going up. She's like, yeah, I'll go check on him. Goes to go check on him. And she's like, yeah, he's fine. He's sitting up. He's eating. Like, he's eating breakfast. And then I was like, okay. And then I had a couple beats here and there, not sustained, VTAC. Like,
oh, you were monitoring?
Check on him again.
He had
Next
BTAX?
thing I called code. He started coding.
Oh,
and then
wow.
Became symptomatic.
Something happens, and
And he was feeling good?
And then I think they ended up transferring him. Yeah. It's like, yeah, I asked Leslie about it. And then later on, I was like, I didn't know if I should, but I asked the nurse, like, hey, are you okay? And she's like, no, girl. I'm like, yeah, me either. 'Cause,
Oh, yeah, you could have. Yeah.
But I'm like, hey, what happened? Like,
Yeah. And you did your job, and she did her job,
Yeah.
right? Like checking, but symptomatic, 100%, right? He was eating.
He's currently now in VTech. She's like, okay, hangs up and like,
Bye. Dang.
Yeah.
He was transferred to ICU, but I don't know if he made it out of it.
Look at this one's breaking HIPAAs. Remember, once he's out of your sight, he's not your patient anymore. But it's cool to talk about the cases, right? So as long as there's no ways for us to identify the patient. Like at this point, you guys identify the patient. You know who that is, right? So like, let's not do that. When you can talk to I'm pretty sure your family is going to be your outlet. So you're going to have to come and talk about the cases and stuff. That's cool. Just make sure if they take it, huh?
No, because they don't understand about that, so I don't.
Yeah, no, for me, it's really cool because, my daughter and I, we're eating or whatever, and we're talking about blood and bones and all this, and she's like, and the boys are like, ugh.
What is your daughter do?
She's chiropractor. So for us, it's, I brought her to the OR when we were at BAMC. I think she was still in middle school or just out, I don't know. And she entered a surgery, and I thought she was like, okay, are you okay? And she's like, eh. I remember it was an arm, and it was all dissected. Remember that doctor that used to dissect everything, plastic, short, that she used to dissect the whole arm for nothing? You don't remember her? I can't remember. She was a short person. I hated her surgeries, huh?
Oh, no, she was for a live patient.
Yeah. So the patient had something here. She will cut here and then dissect both ways and have it all open, looking for something that she couldn't do. I can't remember her name.
Jeez.
Yeah, and my daughter is like, oh, okay, cool. I was like, you either take it or you don't, right?
No one can tell the doctor anything? Like,
No.
it seems a bit excessive.
Do you want to get kicked
Oh
out?
no, and
I
then
would, but like, it's just
good luck with that. Good luck with that. All right, so look at the symptoms of myocardial infarction. I have I think they are, here. This is your form to practice the symptoms of a myocardial infarction. We kind of already talked about some of this, right? The substernal pain somewhere in here. The diaphoresis that we were talking about, that clammy sweat that is cold and weird. They feel cold. I've had a lot of patients that feel like vomiting. And it could be anything, right? When you're not feeling, and you've never experienced a heart attack, so how do you identify as a heart attack, right? Like if you were like feeling nauseous, you don't think it's a heart attack. Mild fever, but you're still cold. And then of course your sounds, when you start getting evaluated, Well, the venous the distension is if other conditions, venous return is happening, but let's just talk about all the symptoms that you can find so you are aware. So why is a mild fever happening in our patient? Because the body is trying to, it's an inflammation response, right? So all the symptoms that the patient is experiencing is trying to respond to the effect of the damage, right? All right, on this one, I gave you, this one I was able to do it correctly. So you have the acute coronary syndrome table map. And then the next page is empty, so you can actually put it together. Like we said before, the NSTEMI is not an emergency. So we can start with, medication, all the things, while we prepare and put the patient in a regular schedule. Yeah.
That when patients are in telemetry, they have a component every 2 hours. Is that what?
But there's other presentations, right? So, because the troponins are high and we have an elevation, it will be STEMI. If we have depression, they're going to be like, okay, we're going to monitor, blah, 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 because it's not entirely, right? It's just part of it. So when we have a STEMI, we have to immediately come, and more likely we are going to perform a PCI, right? Do we know what PCI means? Coronary intervention, PCI.
Oh, that's pretty good.
For coronary,
Yeah.
coronary, yeah.
Okay.
Because we are, right? Because sometimes the lingo, right, is kind of like, sometimes it's not, we don't talk about it and we just go with it and you're like, All right, so the options that we have for the ST elevation or STEMI is definitely going to be a PCI. We are not going to treat PCI with medication only. That's not the solution for that, right? If it's a STEMI, we're going to intervene. Now, when we have an NSTEMI, we are going to start with obviously the assessment. We're going to start with medication, and then we're going to move to the cath lab. I mean, we're not going to fix it with medication, but we're going to start treating the patient with all the medication that we just talked about, right? To start, especially if it's in the middle of the night or it's a patient that it's in observation. We need to get the team together, blah, blah, blah. There's no rush. More likely, we have the way we schedule in the cath lab is obviously the STEMIs are going to have preference. The scheduled PCIs are going to have preference over an NSTEMI. So sometimes the NSTEMI is going to sit there, right, as long as it's monitored. Yeah. And there's no changes. Or look at that, cabbage, PCI or cabbage. Depending on, this is going to be depending on findings. If we have a patient that has multiple lesions, either or, STEMI or NSTEMI, if there's multiple lesions, different vessels that are injured at the same time, we're going to send the patient to the OR. And we're going to do like this. We're doing the PCI, we see the image, and everybody's going to go like this. That means open heart surgery, because there's so many injuries that we can choose. We can choose. So the best route for the patient will be a cabbage. However, some patients are not accepted in the OR for certain conditions. So we're going to reevaluate, and we might do PCIs, a series of PCIs to fix the different vessels. And it's going to be super risky because the patient is already like...
The maximum amount of patients per case.
Is that an answer? I don't know.
Is it
Different vessels? Different vessels?
Yeah.
Typically, we're going to go for one vessel. If it's a STEMI, say it's a STEMI, the patient has one that is full and one that is NSTEMI. We're only going to treat the one that the patient came for that it created the occlusion. If the patient comes in the middle of the night and the patient has several, or say two, we're going to evaluate because then we go into the insurance type of world that is not going to let me just repair the patient. I'm just going to repair, if it's an emergency, just what is causing the case, this case. Secondary is going to be another case, right? So they can bill differently, they can plan or things like that, but more likely billing situation, believe it or not. Yeah. Now, if it's a cabbage, then they do as many as they need. So that one is very simple to accommodate here, right? Oh, that's the double that I put. Well, we can already talk about this. The presentations, the main presentations are going to be for us as a clinician, or the ER is going to be obviously the EKG and the serum markers, right? The troponin, the creatine kinase, and imaging. We might get an echo. Yes.
What does the 2 weeks and then 48 to 72 hours mean? Like,
So remember that we said there's different things. If it's an NSTEMI, are we gonna have troponin?
biomarkers? Yes. Wait.
No.
No. Right. So it's gonna start like. So we're gonna have to monitor depending on, because it's the entire ACS. So we're talking about angina, NSTEMI, and STEMI. So we're giving the overall. How do we monitor, right? So if it's because to me, more likely this is the time that really happens for a STEMI. You know, because patients, by the time they decide, by the time they're like, oh, do I call, do I not? And so within 3 to 4 hours, we should be able to get this information and determine whether or not it is an the acute coronary syndrome. Does that make sense? Okay. All right, I think I have 2 more. All right, so this is the TIMI risk score, thrombolysis and myocardial infarction. And you're gonna have a few questions about this test. This is how we kind of grade. You know how, remember we're talking about the babies and they get the APGAR, right? So they get evaluated. That is the same thing for patients that are presenting a heart attack. So if my patient is 66 years old, is going to have 1 point already just for having 66 years old, even though 66 right now is like 50s, right? Maybe exercises and everything, but just for the age is going to be marked. If he has more or equal 3 risk factors for coronary artery disease, which we already talked about, what are some of the factors for coronary disease?
Obesity, smoking.
Oh, never mind. 5 and 6 are coming up, right? This is when we come back from the break. But chapter 5 and chapter 6, it's coming up. But some of the factors will be lifestyle, metabolic conditions, other diseases, et cetera, smoking, right? Drinking, et cetera. Known coronary stenosis by, say, the patient already is being treated, we start getting information, already kind of have an idea, an echo or whatnot. If the patient already presents with that prior, then points. The ST segment deviation means elevation or depression. Means that deviation is not normal, right? So when we do the EKG, when we take the EKG, if it's up or down, point. At least 2 chest pain presented in the last 24 hours. So these are the questions that we ask the patient, right? So use of aspirin in prior 7 days. And of course, the elevated troponin on the kinase. So if the patient presents with all this, the score is going to be bad, right? And then I was looking into some chart, and different charts give different information about how many points are given, like 1 point, 3 points, 2 points. So I just didn't want to confuse us with that. So just know that these are the markers for the TIMI score. You are going to have maybe one question, maybe two questions on your RCIS about this, right? But it kind of makes sense, right? Every patient that we just talk about all this, patients that, except for the age, right? The age, I think, is relative, completely relative. I think that should be out, maybe because I'm getting close. Yeah.
No.
Yeah. I'm just reverse. I just turned 56, so it's like,
So how many of those do you need to have in order for it to be like really very serious?
so well, if you have them all right, but I think it was that's what I was saying. It was not very defined how many. This is just you're bad, but we're just finding how bad you are. Does that make sense? I mean, you're presented with all this, and it's either yes or no situation. It's not like A, B, C, D, right? It's like complete or incomplete. Yes, a little bit more on that, so we can have clarification. All right. Now on this one, I have the acute treatment for STEMI. On this one, I give you the diagnosis, right? So it does have a line here. It's for you to fold it.
Oh, sorry.
So you can describe, huh?
It's okay.
So you can start working on it. So it's a test, right? When you don't have anybody to study with, it is where the EKGs are showing. Yeah, so you can, right? And then just close. And then
See the damage in the muscle, or why is it not?
the who?
She can be.
Because it's the AAC is just, how do we diagnose it? That one will be testing, right? So we already know that the serums are a factor, but then this is the, let's say the practical, something we can do, right? Because the lab, we're gonna send it out. So for us, this is something that we can do. Okay. All right, on the acute treatment for STEMI, obviously, we're just talking about STEMIs, right? This is non-angina and STEMI. This is just for STEMI. Obviously, we're gonna do PCI within the first 90 minutes of knowledge, right? And the knowledge could be when the patient walks into the ER or when the patient gets in the ambulance. The ambulance calls. If they make the mistake of calling us, the time starts there. Yeah, or where the patient walks into the ER and say, I have chest pain, immediately press the time. Or if it's a patient that is in hospital, then starts at that time when maybe the defibrillation or something happens, yeah? So I want you to make the description as much as you want there on PCI, right? On here, I have an image, so you can, whatever PCI means to you here. In the therapy, we did talk about the therapy. Again, you're gonna have the full class on medication, but we're gonna try to start preventing the fibrin from building. This is what it means, right? So write everything that you remember there.
You want also to know about like the promise therapy and all that.
Well, it's included in here.
Oh.
Yeah. And then we're also gonna give the statins, the antagonists, and the ACE inhibitors as well. So this is the treatment for a STEMI entirely. Patients that leave with a heart attack or a STEMI, they take medication for the rest of their lives. So it's like 5 pills in the morning, 5 pills at night, blah, blah, blah. So yeah, it's not fun. And a lot of people are not compliant. And those are the ones who are gonna come back and come back and come back. Or die, right? Like this lady that I told you about the aorta, she was supposed to have an appointment and she canceled it. She's like, no, I don't wanna go. Lady. All right. I gave you the last two for you to fill out. These are the complications that could occur after myocardial infarction. Patients can develop arrhythmias, blocks. They might need pacemakers after this. So they become frequent shoppers. They have the frequent shopper card with points and everything. You sometimes see people often with different things that you take a chest x-ray and you see the defibrillator, or you see the pacemaker, or you see the whatever device that they might have. There's patients that have everything that we can find on the book, all the services that we can provide. Pericarditis, it's obviously one of them, and you're gonna be reading about pericardial diseases this coming week, and then we talk about next week. Ventricular rupture, obviously, because if the tissue gets damaged, there's a possibility, and depending on how the endothelium, how the muscle is on those patients. So I want you to study that and then come and test yourselves, right? Like write as many as you can, right? And then the same thing for the after myocardial infarction. What happens? What happens after that? So the patients are going to be, like I said, in a lot of medications, right? And then patients, we also have one area that is called cardiac rehab. Patients have to go to cardiac rehab. Life is not the same after a heart attack. You know, even exercising again, walking again, moving, and depending on what they, the complications that they might have gotten after the. What about if they had a cabbage? Exercise? You think a push-up or a pull-up is fine? It's not, right? So they're going to have to attend rehabilitation, and I think rehab is for a year, depending on, right? Yeah. So depending on what happened to the patient, but just exercising becomes like really hard. And then, like I said, a lot of medications, arrhythmias, coronary disease, continuous coronary disease, because patient who has already a lesion, more likely, and it's probably legs, and it's probably head, and it's probably renals, and it's probably everywhere. And well, left ventricular dysfunction. Why do you think that left ventricular dysfunction is presented after STEMI? What is a dysfunction? Not functioning properly, right? Why? A malfunction.
Because it's usually the widowmaker that's toxic, prohibits a lot of that oxygenated blood into that side of the heart.
But not just widowmaker, right? We're talking about heart attack, period.
It's trying to make up for it. It's trying to make up for the slack now. So it doesn't matter where it happens now that LV is trying to really push it now.
Because remember, all these cells died,
Right.
and now we have minus 10% or whatever, 10% that everybody else has to come up with. So the ventricle is used to only doing this job, right? It's 90%, and now it has to come up and do a little bit more. Definitely a compensation, and we're going to see also. I don't think it's so much megaly, because there's not the conditions for that, but the work. So think about somebody who's thin and they still have to do the work, as opposed to like, muscle person. Does that make sense? So that's what the left ventricular dysfunction, depending on how much tissue did we lose. And then of course, underlying factors, smoking, diabetes, hypertension, which is what I was looking into for those videos, like to talk more about lifestyle, about how to control diabetes, how to control the hypertension, not just like, oh, go get it checked. Yeah, but how do we prevent hypertension? Maybe getting into cardio classes, maybe walking a little bit more. That's really what I wanted to. Smoking is the number one factor that is preventable. That's so if nobody smokes here, we're already points to you.
We're gonna see them in the lab.
We're gonna see in the lab or outside, right? Outside of the lab, and then.
I can't see that.
Oh yeah, you do, but that doesn't mean you don't, right? Like, does that make sense?
Could you imagine that?
With all the time. All right, so this is just a sample how the chapters are coming. We have the 5 and 6. You have pericardial diseases next week. You can do the same thing with your material, right? Go through the chapter. Everything that you saw on this PowerPoint and in your papers is from the book. I took time to do ting, print.
Thank you.
But what I'm saying, no, don't thank me. I want you to do it. I want you to also do it, right? Go through. I know the chapters are like this long, but All the information is there. We just need to be patient. You know, we feel overwhelmed because it's too much. Take your time to read. This is what we need to know to serve our patients from this chapter on. Pericardial, and then we have chapters 5 and 6, week 7, and then we have our final
Okay, right.
Wait,
Huh? on the 10th, and it's going to be at 1 o'clock on that Wednesday.
oh, what's on the finals? How many files are there?
It's 3 of them, right, back to back.
For us, it's 2. So you have one with me, one, the 1313 lab, and I don't know if Mr. Ochoa has anything for his.
Oh, yeah.
Is it on the same day?
Yeah, but he said it was gonna be Wednesday, and then we're gonna come there.
I thought you said that, because
No, she didn't say that. No, she said hers was after her.
Yeah, because we reserved the time for the 2 of us.
the last time I told you mine for his.
Yeah, that was his final, but I don't know if he has any final, because I know he didn't have a midterm.
He told us that it was gonna be.
There is a final? Oh, it's a comprehensive? Okay, so
It's gonna be his.
let me,
I think he probably.
I mean, he only gave us 10 case studies in like 1 week, so I'm pretty sure.
dang. Well, let me talk to him, and if his is on the same day, because I already have a room reserved like 4 months ago, so we can move it. So, because I know it's a lot to do all the finals in one day. So let me talk to him, and I'll let you know.
I thought you were gonna say, okay, we're gonna have.
No exam, no exam, yeah. No,
Okay.
party for the room. All right, well, I'll see you guys. Happy Thanksgiving. Be safe, yes.
I know